Karnofsky Performance Scale, KPS, functional assessment for hospice eligibility. Learning objectives. Understand history and development of KPS. Apply accurate scoring methodology. Recognize hospice eligibility thresholds. Document KPS appropriately. Understand differences between KPS and PPS. What is the KPS? Developed in 1949 by Dr. David Karnofsky, originally for chemotherapy tolerance, now widely used in oncology, hospice, and palliative care. Why KPS matters in hospice. Helps determine hospice appropriateness, predicts survival and decline, standardizes functional assessment, supports Medicare documentation. The Karnofsky Performance Status, KPS, is an 11-point scale ranging from 0 to 100% in fixed 10% increments, designed to measure a patient's functional ability and level of independence. A score of 100% reflects normal function with no evidence of disease, while a score of 50% indicates the patient requires considerable assistance with daily activities and is unable to carry out normal work. At the lower end of the scale, 10% represents a moribund state with rapidly declining function, and 0% signifies death. This structured progression helps clinicians consistently assess decline and determine appropriateness for hospice services. The color zone model organizes functional status into 4 clear ranges to support hospice eligibility decisions. Patients in the green zone, 100 to 80%, demonstrate good overall function and are usually not appropriate for hospice. Those in the orange zone, 70 to 40%, show noticeable decline with increasing care needs and may qualify depending on documented progression. The pink zone, 30 to 10%, reflects significant functional loss and advanced disease, making patients in this range typically appropriate for hospice. The gray zone, 0%, represents death. To score a patient accurately, begin by assessing their current functional abilities, including work capacity, activities of daily living, and overall activity level. Use these findings to identify the correct category: A, 100 to 80%, B, 70 to 50%, or C, 40 to 10%, and select the most accurate score within that range, choosing the lower value when the patient falls between 2 levels. Throughout the process, consider the entire clinical picture rather than isolated observations to ensure the score truly reflects the patient's functional status. The category breakdown groups patients by functional status to guide scoring and eligibility decisions. Category A, 100 to 80%, includes individuals who maintain normal activity but may have varying symptoms. Category B, 70 to 50%, reflects patients who are unable to work and require assistance with daily tasks. Category C, 40 to 10%, represents those who are significantly disabled and often need institutional-level care due to extensive functional limitations. Hospice eligibility based on KPS follows predictable functional patterns. Patients scoring 70% or higher generally maintain too much independence to be hospice appropriate, while those in the 50 to 60% range may qualify if there is documented decline or increasing care needs. Scores between 30 to 40% typically indicate significant functional loss and are considered appropriate for hospice, and patients scoring 10 to 20% show profound impairment and are clearly eligible due to near total dependence and rapid decline. A patient scoring KPS 70% remains fully independent in all activities of daily living but is no longer able to work due to significant fatigue and reduced stamina. Although they can manage personal care without assistance, they spend most of the day at home and demonstrate a noticeable decline in activity tolerance. This presentation aligns with the definition of 70%, reflecting a patient who can care for themselves but cannot carry on normal activity or employment. A patient scoring KPS 50% requires assistance with essential activities such as dressing and bathing and demonstrates significant functional decline. They experience severe dyspnea that limits even minimal exertion and necessitates frequent medical attention. Their instability is further reflected in multiple recent emergency department visits, supporting a 50% score that indicates considerable assistance is needed and normal activity is no longer possible. A patient scoring KPS 80% is able to work part-time, remains fully independent in all activities of daily living, and experiences only mild symptoms that have minimal impact on daily functioning. Their preserved activity level and independence align with the definition of 80%, indicating stable functional status and making them not hospice appropriate based on KPS alone. When comparing the Karnofsky Performance Status, KPS, to the Palliative Performance Scale, PPS, The key difference lies in how each tool measures decline. KPS evaluates a single domain, functional ability, and is most effective for conditions like cancer and HIV, where decline is primarily functional. PPS, by contrast, assesses 5 domains: ambulation, activity level, self-care, intake, and consciousness, making it more detailed and better suited for non-cancer diagnoses where decline is multidimensional. This broader structure allows PPS to capture a more nuanced picture of overall deterioration. When documenting functional status using the KPS, include the current score, the previous score, and a clear description of the change or decline observed over time. Provide a concise clinical rationale supported by objective findings that justify the selected percentage, along with any supporting observations that demonstrate functional loss. For example, documentation might read, KPS 50% based on requiring considerable assistance with bathing and dressing. This level of detail strengthens eligibility and ensures consistent, defensible scoring. Common scoring errors include using half scores, assigning scores based on a patient's potential rather than their actual current function, and inflating scores to reflect how the patient appears on a good day instead of their baseline. Additional mistakes include failing to reassess regularly, overlooking the impact of symptom burden on functional ability, scoring bedbound patients too high, and neglecting to document the clinical rationale that supports the chosen percentage. These errors weaken eligibility justification and compromise accurate clinical representation. A high-quality KPS score requires confirming that the patient's actual function was assessed and that both ADLs and overall activity level were considered. The score must be assigned in 10% increments, supported by a clearly documented clinical rationale, and compared to the previous score to show change over time. When a patient falls between 2 levels, the lower score should be selected to ensure accuracy, consistency, and audit defensible documentation. The Karnofsky Performance Status, KPS, is a validated tool in use since 1949, providing a reliable, standardized way to measure functional status over time. It uses an 11-point scale in 10% increments, which can be grouped into 3 functional categories that reflect normal activity, reduced ability to work with increasing assistance needs, and severe disability requiring extensive care. In hospice practice, a functional threshold at or below 60% is often used as a key indicator that a patient may be appropriate for hospice, especially when supported by evidence of ongoing decline. To make KPS both clinically meaningful and audit defensible, it is essential to document thoroughly, clearly linking the chosen score to observable function and changes from prior assessments. Because performance status can shift quickly with serious illness, clinicians should reassess regularly and use the tool consistently across patients and disciplines so that scores accurately reflect trajectory and support sound eligibility decisions.